Hi, my name is Anushka, and today I will be talking about the symptomology, diagnostic criteria, and examples of symptoms in obsessive-compulsive disorder. First, I would like to talk about the diagnostic criteria and features of obsessive-compulsive disorder, or OCD. Generally, OCD entails the presence of obsessions and compulsions. In order to meet full criteria for OCD, an individual must be experiencing obsessions, compulsions, or both. Obsessions are best described as repetitive and persistent thoughts, urges, images, or feelings, and they are typically intrusive and unwanted. Oftentimes, they cause the individual to feel anxious and distressed. These intrusive thoughts are not pleasurable and not experienced as voluntary. Additionally, an individual with OCD will attempt to ignore or suppress such thoughts, urges, or images. They might also try to neutralize them with some other thought or action. Compulsions are best described as repetitive behaviors or mental acts that an individual feels driven to perform in response to an obsession or according to rules that must be rigidly applied. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress triggered by the obsession or preventing some dreaded event or situation from occurring. These behaviors or mental acts, however, are not connected in a realistic way with what they are designed to neutralize or prevent, or they are clearly excessive in nature. It's important to note that compulsions are not performed for pleasure, although some people experience relief from anxiety or distress upon completion of the compulsion or compulsions. For young children, articulating these behaviors or mental acts can be particularly difficult. To further meet DSM-5 criteria for OCD, an individual's obsessions or compulsions must be time-consuming or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Additionally, an individual's obsessive-compulsive symptoms cannot be attributable to the psychological effects of a substance or another medical condition, and the disturbance cannot be better explained by the symptoms of another mental health disorder. Several specifiers also need to be assigned when making a diagnosis of OCD. The diagnosing clinician should specify if the individual has good, fair, or poor insight, or absent insight and delusional beliefs. Good insight is indicated when the individual recognizes that obsessive-compulsive disorder beliefs are definitely or probably not true. Fair insight is indicated when the individual recognizes that the beliefs may or may not be true. Poor insight is indicated when the individual thinks obsessive-compulsive disorder beliefs are probably true. And absent insight and delusional beliefs is indicated when the individual is completely convinced that their beliefs are true. One final specifier is the tic-related specifier, which is added if the individual has a current or past history of a tic disorder. One way to illustrate the connection between obsessions and compulsions is to consider OCD as a cycle. Consider someone with OCD. First, they have a distressing or bothersome thought. In an effort to alleviate the anxiety experienced by this thought, they engage in a compulsion. Engaging in the compulsion leads to a feeling of relief. The compulsion is associated with anxiety reduction, so when they experience another obsession, they engage in a compulsion. This continues in a cycle over and over again. In regards to prevalence of obsessive-compulsive disorder, the 12-month prevalence of OCD in the US is about 1.2%. The 12-month international prevalence of OCD is between 1.1 and 1.8%. Boys are more commonly affected than girls during childhood, and women are affected at a slightly higher rate than men in adulthood. As for suicide risk, as many as about half of all individuals with OCD have suicidal thoughts. Suicide attempts are reported in up to a fourth of individuals with OCD. Individuals with comorbid depressive disorder have a higher risk of attempting suicide. In terms of development and course of OCD, the mean age of onset of OCD is around 19.5 years in the US, according to the DSM-5. About a quarter of the cases in the US start before the age of 14. The onset of symptoms is usually gradual, but acute onset of symptoms have been reported. Untreated, the course of OCD is typically chronic, with symptoms that ebb and flow over time. Some individuals have an episodic course of OCD. Without treatment, adults' remission rates are low. A childhood or adolescence onset of OCD can lead to a lifetime diagnosis of OCD, and about 40% of people with childhood or adolescence onset may experience remission by early adulthood. Of note, compulsions are more easily diagnosed in children than obsessions because compulsions are typically more observable than obsessions. There are several hypothesized risk factors and prognostic factors for OCD. Temperamental factors suggest that people with more internalizing symptoms, higher negative emotionality, and behavioral inhibition in childhood are more likely to have OCD. Environmental factors suggest that physical and sexual abuse in childhood, or other traumatic stressful events, or various infectious agents and post-infectious autoimmune syndrome are potential contributing factors to OCD. Genetic perspectives suggest familial transition of OCD due in part to genetic factors. Psychological perspectives suggest that dysfunction in the orbitofrontal cortex, anterior cingulate cortex, and striatum are implicated in OCD. OCD is associated with decreased quality of life and severe occupational and social impairment. Impairment can be caused due to time spent having obsessions and completing compulsions. Avoidance behavior can also restrict functioning. For example, if an individual has obsessions about harming their family members, they may avoid having relationships with these family members. When OCD begins in childhood or adolescence, individuals may experience developmental issues. For example, children who avoided socialization with peers may struggle to leave their family home or live independently as young adults. Functional consequences of this can include very few significant relationships with non-relatives, a lack of autonomy, and a lack of financial independence from their families. Setting rigid rules determined by OCD can also lead to family dysfunction. For example, if an individual with OCD refuses to have any visitors come to their family's home, this may impact their relationship with their family members. Some differential diagnoses for OCD include other anxiety disorders, major depressive disorder, other obsessive-compulsive related disorders, eating disorders, tics and stereotyped movements, psychotic disorders, other compulsive-like behaviors, and obsessive-compulsive personality disorder. Individuals with OCD often have other psychopathology. Many adults with OCD have a lifetime diagnosis of an anxiety disorder or a depressive or bipolar disorder. Comorbid anxiety disorders include panic disorder, social anxiety disorder, generalized anxiety disorder, and a specific phobia. Up to 30% of individuals with OCD also have a lifetime tic disorder. Having a comorbid tic disorder is most common in boys with a childhood onset of OCD. So when many people talk about OCD, they think about obsessions related to contamination and compulsions around excessive cleaning. It's important to note, however, that the specific content of obsessions and compulsions can vary across individuals. In other words, OCD does not look the same for everyone. With that being said, there are common dimensions or categories of obsessions and compulsions. Common themes tend to include cleaning, symmetry, forbidden or taboo thoughts, and harm. Symptoms around cleaning typically involve contamination obsessions and cleaning compulsions. Symmetry symptoms tend to involve symmetry obsessions and repeating, ordering, and counting compulsions. Forbidden or taboo thoughts tend to encompass aggressive, sexual, or religious obsessions and neutralizing compulsions. Lastly, symptoms around harm typically involve obsessions about harming oneself or others and checking or reassurance compulsions. Some individuals have difficulty discarding objects and accumulate or hoard objects as a consequence of typical obsessions and compulsions, such as fear of harming others. Interestingly, the symptom themes I just described seem to occur across cultures and remain relatively consistent among adults with OCD. Additionally, individuals often have symptoms in more than one dimension or category. There are a range of affective responses that are associated with OCD, including intense anxiety and panic attacks and strong feelings of disgust. Additionally, when completing compulsions, some people report experiencing a distressing sense of incompleteness or uneasiness until things feel, look, or sound just right. It is common for individuals with OCD to avoid people, places, and things that trigger obsessions and compulsions. People with contamination fears might avoid public situations to reduce their exposure to feared contaminants, so they might avoid restaurants or public restrooms. Similarly, people with intrusive thoughts about harming others might avoid social interactions or situations. References for the information I presented in this lecture will follow at the very end. This concludes my lecture on the symptomology, diagnostic criteria, and examples of symptoms of obsessive compulsive disorder. Thank you.